In this third and last part of week 6, we're going to look at some examples of studies that have used Markov modeling methods. Just to recap, Markov models are used for stochastic processes, and these are random processes that occur over time, and they're good for applications in which you have continuous risk, you have multiple events or events that occur multiple times over time, multiple events, and also when the timing of events is important, And we talked about how they are divided into states and how to build an analysis using Markov models. So let's look at examples of how these modeling methods have been used in the literature. So we're going to use two examples. One is the cost effectiveness of a medicine called sildenafil nitrate, and a lot of us know it as Viagra. And the other one is one of my own studies, which is the cost effectiveness of universal access to modern contraception in Uganda, which was a policy analytic model using Markov modeling methods. The study on the cost effectiveness of sildenafil, also known as Viagra, was published in the Annals of Internal Medicine back in 2000 and was authored by Smith and Roberts, and it's really one of my favorite Markov models, and I used to refer to it a lot when I was learning these methods. The background to this study was that you have some 30 million American men who have erectile dysfunction, so it's a large market. And at the time, back in the late 1990s, before 2000, there weren't very good methods for erectile dysfunction. They included things like penile injection and vacuums and intraurethral medication, which weren't very acceptable to many men. But sildenafil came onto the market, and it was an oral medication, and it was much more acceptable, but it was costly, so there was a trade-off there. It was costly, and it could lead to major side effects, and it could lead to death in people who had cardiac problems. So there was a risk of death, especially if people were taking nitrates, which are a very common medication for people who have angina pectoris or chest pain due to cardiac vascular problems. But reimbursement by insurance companies at the time was very contentious. So the question was, why pay for a drug that treats a non-life-threatening disease given its high cost and the potential for harm? So this study was performed to estimate whether sildenafil was cost effective, and to support decisions by reimbursement bodies for reimbursement, so that health insurance companies and HMOs or health maintenance organizations could pay for the drug. The study was a cost utility analysis, and this is important because a lot of the problems to do with erectile dysfunction are to do with quality of life, because like we said in the previous slide, the condition isn't immediately life-threatening, so it's quality of life heavy. Life expectancy, of course, is important as well, but only in the context of the potential mortality from side effects of the drug. And they used two perspectives, both the payer and the societal perspective, and they followed the reference case. I think in a later video we'll talk about the reference case, and they built a Markov model. And the comparators were sildenafil or do nothing. And this is important because there were other methods, but they didn't want to compare to other methods because they weren't very acceptable at the time. So they compared Viagra to not using erectile dysfunction medicines at all in a population of patients who had erectile dysfunction. So here is the Markov model for this application. You had a 4-state Markov model with erectile dysfunction, no erectile dysfunction, morbidity from therapy, and dead. And you can see the arrows which indicate the acceptable transitions. So even just with this diagram, you can build the matrix the transition matrix for this analysis. Essentially, you can just put, the different states: erectile dysfunction, no erectile dysfunction, mobility, and dead. And you can do the same: ED, no ED, mobility, and dead. And you can put your different transitions here, and you have some that are not allowed. For example, the dead to anything but dead is not allowed. So all these would be zeros, except this one, which would be a 1. And you can fill in the others based on the arrows. So for example, erectile dysfunction to mobility, you have a transition there, but you don't have a transition from mobility to erectile dysfunction. So you don't have mobility to ED. Here you don't have probability. So this was the modeling framework used in this study. Briefly, let's look at the parameters that they had, and this is in their parameters table in the paper, and I added this paper to your reading list. But let's look maybe at the utilities. The baseline value for men with 60 years of age was 0.87, so they are not 100. Then there was a disutility of erectile dysfunction, so 0.13. Now remember that they are using a disutility, which is a decrement from a state of health. And then they had mobility. If it was acute mobility, you had a utility of 0.3, and chronic mobility, you had a utility of 0.5. And each tablet of Viagra was $50, $52 right here. And then they had medical costs: short-term $10,000, $5,000 for long-term, and they had indirect costs right there. For the transition probabilities, they had, effectiveness of sildenafil was nearly 70%. They had a 1% mobility and a very small mortality. No, a 10% mobility and a 1% mortality. And actually, if you read the paper, this is a very high mortality. It's higher than is expected. And they had this absolute increase in the death rate and, recurrent erectile dysfunction. So they had some other parameters in there. So if you look at the results, you have two perspectives. You have the societal here and the third-party payer, and no drug treatment incurs no costs, and sildenafil was nearly $4,000 from both perspectives. And there was a small jump in QALYs, a 0.3519 jump in QALYs, and this was to do with the avoidance of the disutility of erectile dysfunction. And Viagra added nearly $4,000 in costs because you had a comparator with zero cost. And if you do the calculation, the incremental cost effectiveness ratio is some $11,000 or so per quality adjusted life year, which in the US would be cost effective. No question there, cost effective. So the conclusion of the study was that Viagra was cost effective. So the conclusion, and this is a direct quote, they said that in an analysis biased against the use of sildenafil, the cost effectiveness of sildenafil treatment compared favorably with other accepted therapies for other medical conditions. And just as a side note that I added here, it's nearly $2 billion in annual sildenafil sales worldwide between 2003 and 2014. So it's a major drug, and it ended up being one of these drugs that is used by a large number of people. The next example is this study published in PLOS ONE, and I was one of a group of authors, and it was the potential cost effectiveness of universal access to modern contraceptives in Uganda. So as a background, Uganda has high fertility and a high population growth rate. So you have a fertility of 6.7 and a growth rate of 3.2%. It's one of the highest in the world, actually, and only 31% of women had access to modern contraceptives at the time, and a lot of births were unplanned. And women tend to have more children than they desire, so unintended pregnancies could be attributed to both a lack of contraceptive use, but also some contraceptive failure. And we know that contraception has many benefits. In addition to reducing fertility, it enables families to plan better, And so the question was, given the potential benefits of contraception, should the government invest in increasing access to contraceptives? And we also had this rationale that at the time, per capita expenditure in Uganda on healthcare was $24, a very small amount. And so the question is, what do you pay for and what do you not pay for? So should the government even prioritize an intervention like contraception? So in this study, we compared what we call the current contraceptive program. And this was a contraceptive program in which there was a coverage rate equivalent to what it was then. So it was a status quo comparator, status quo. And we compared it to a hypothetical new contraceptive program, a hypothetical program. And in this program, you would have 100% access to modern contraceptives. This means that every woman who wanted to use modern contraceptives could actually get access to them through the government system. So just quickly, the methods, we used a Markov model like we've been discussing, and it was based on states of sexual activity, contraceptive use, and pregnancy. And we're going to look at that model in a minute, but the model followed a hypothetical cohort of 15-year-old Ugandan girls over their lifetime horizon. And this 15-year-old was chosen to mimic sexual debut, so the beginning of sexual activity, sexual debut. Of course, it was an assumption because we don't know the exact timing of sexual debut. And we did two perspectives, the societal and the governmental. And the governmental perspective is, in this case, the Ministry of Health, because the Ministry of Health pays for healthcare in Uganda. Most of the data came from the DHS, the Demographic and Health Survey, and the main outcomes were cost per life year gained and cost per daily averted. But we also had cost per pregnancy averted and cost per unit of fertility reduction. And the new contraceptive program was considered cost effective if its incremental cost effectiveness ratio was less than 3 times Uganda's GDP per capita. So we had a threshold decision rule in this study. Threshold decision rule. So here is the model, and it's a bit bigger and more complex than the examples we've been looking at, both the classical 3-state Markov and the one for sildenafil, which had just 4 states. So this one had 7 states, and you look at the states, you have not sexually active, and you have modern contraception, you have intentional non-contraception, you have unintentional non-contraception, and this one allows people to get pregnant and have babies. So this is the procreation state. Procreation, because some people intentionally don't want to use contraceptives, they want to have babies. Then you had the traditional contraception state. Then you had a state of pregnancy and dead. And this dead state, because there were many transitions, so we didn't put arrows in the diagram, but you can think of arrows coming from every state to dead. So every state has an arrow coming to dead. But we just didn't put it in there to avoid having a very busy figure. And we had age-specific transition probabilities, and we had some transition probabilities that didn't vary by age. But for moving from not sexually active to intentional non-contraception and moving between these states, like unintentional non-contraception to pregnancy, all these were based on DHS data, and they were in 5-year tranches, in 5-year groups, in different 5-year groups. So the transition probabilities were allowed to change over time. Like the probability of pregnancy is static up to age 29, but reduces a little bit if you go over 30. And between 40 and 44, it's even smaller. And as you approach menopause, it's even smaller. So some of the transition probabilities were allowed to vary over time. So here are the other transition probabilities, and these ones were static. So from moving from, for example, pregnancy to intentional non-contraception was a small percentage of 3%, and so on and so forth. I don't want to go into all the different probabilities, but there's an important one down here, which is from pregnancy to dead, which is an indication of maternal mortality. This is maternal mortality, and this is an important parameter, maternal mortality. So the probability that a woman will die during pregnancy. Let's look at some other data. We had pregnancy complications, miscarriage, ectopic pregnancy, abortion, and stillbirth. We had the child outcomes, neonatal mortality, infant mortality, child mortality, life expectancy for children at age 2.5 in Uganda. And then we had days lost for maternal conditions, 0.272. So these were just some of the data that entered into the decision analytic modeling framework using this Markov model. So some more data, and these data are on costs. So from a Ministry of Health perspective, contraception is about $26, and from a societal perspective, it's about $39. And I have to say that in this model, the cycle time was 9 months. 9 months, and the reason we used 9 months was to mirror the length of pregnancy, because we had a pregnancy state and it wasn't very flexible. We couldn't say that pregnancy lasts a year. So we calibrated the model to have essentially a cycle time equivalent to pregnancy to account for that pregnancy state. So at the 9-month cost of contraception was $39. And then we had pregnancy costs, which are higher from a societal perspective, because we include indirect costs, and we measured these indirect costs using the human capital approach, indirect costs. And we used productivity loss was based on the human capital approach, and this number here is the GDP per capita, the GDP per capita for Uganda at the time. So here are the results of the study, and we presented this cost consequences style analysis, and it was for a cohort of 100,000 Ugandan women, and remember that we had 15-year-olds and following them to the lifetime. So if you had 100,000 of those women, this is the kind of results you would get. So if you look at the difference column, it would reduce, for 100,000 women, it would reduce costs by nearly $4 million. It would reduce costs to the government by nearly $5 million. Pregnancies would reduce by 160,000. It would increase discounted life years. It would increase them by 9,000, and you can go through and look at different outcomes. But if you think about this on a cost effectiveness plane, let's draw a cost effectiveness plane here. And you have the cost axis here and the effectiveness axis here. This intervention, the new contraceptive program, is not in the northeast quadrant. It's not. It's in the southeast quadrant, because it reduces cost, decrease in cost, and increases effectiveness. And this is a kind of intervention that we call a dominant intervention. And this is an intervention that, as a policymaker, there's no question that you should recommend this intervention or you should implement this intervention. So our conclusion was that the new contraceptive program, in fact, is cost effective, and in fact it is cost saving because it saves money. It's cost saving because it both reduces cost and there's a benefit. There's an increase in benefits. So these were the results of this study. And just to read the conclusions, we said that providing universal access to modern contraceptives in Uganda at the time appeared to represent a comparatively efficient use of scarce healthcare resources, and that policymakers in the Ministry of Health and other stakeholders and development partners should urgently consider concrete steps to increase access to modern contraception to women that need these services. So this marks the end of week 6, in which we learned about Markov models. And these are important models for performing economic evaluations of chronic diseases. So I hope that at the end of this week I've turned you into Markov modelers, and if I haven't succeeded in doing that, I at the very least hope that when you read papers in the scientific literature that use these methods, you will be critical reviewers of these papers or critical analysts of the methods used in these papers. Thank you very much for your attention this week, and I'll see you next week, in a week that we will discuss the cost of illness. We shall discuss cost of illness methods.